Welcome, everyone. Happy February. I don't know where January went, but we're here in February, and I am so excited today because we haven't gone live in the last couple of weeks, and we thought, what a great way to kick off February and to talk about heart health, heart health, and migraine. And so, joining me today are two fantastic women. Can't wait for you to hear from them, Dr. Christine Lay and Dr. Martha Galati. Dr. Lay, will you just tell people real quick what your background is?
Sure. I'm a headache neurologist based at the University of Toronto, and my practice is 100% dedicated to people living with headache and migraine, and primarily migraine. And therefore, my practice is really mostly women. And it's been a great experience to be able to afford women and help women find better quality of life through the right strategies and the right actions that we take to get them on the best, safest treatments.
Thank you, Dr. Lay. And we know you're an integral part of what we do at American Migraine Foundation. And sometimes I forget you're not a paid staff because you spend so much time with us, but we're so grateful for all you do. And Dr. Galati, will you tell folks what your background is and what you're doing currently and what your background is?
I'm Martha Galati and I'm a cardiologist. I actually, my specialty is both preventive cardiology and women's cardiovascular health. I was previously the associate director of the Barbara Streisand Women's Heart Center, and I now, just a few months ago, moved to Houston, Texas, where I am the director of the Davis Women's Heart Center at the Houston Methodist DeBakey Heart and Vascular Center.
Well, I think that if as I am hearing both of your backgrounds, that's just amazing and remarkable that we have both of you. That your schedules aligned to allow us to be on a call today, but thank you both for being here. And we want to talk about, this month being Heart Month, and I kind of just call it Heart Health Month because I think that the focus really becomes how can we get more information out to patients about heart issues. And I think it ties in so nicely with how many of our patients are migraine patients. And they'll say, oh, well, how does my heart health play into this? So I want to start with you, Dr. Galati. From a cardiology perspective, what's the biological connection between migraine and the heart?
Well, I think, and I'm no migraine expert. That's why we have Dr. Lay here. But I would say the way I think of it is that whatever's going on with migraines is vascular. And what it obviously vascular means it's also connected to the heart. And we have a lot of evidence that having migraines is a risk factor for cardiovascular disease. So much so that a few years ago, one of the risk assessment tools that we use, something called QRisk-3, that's used more often in Europe to assess somebody's individual risk, actually incorporated migraines into the risk score. Now, in the US and the Canadian ways of doing risk assessment, migraines has not yet been something that's in our risk scores, but I really think it should be because there's such a connection between whatever's going on vascularly that's causing migraines has the potential to also be a window to the heart.
Hmm. Hmm. Oh, that's so well said. I like that, the idea of the window to the heart. Dr. Lay, anything you would add from the migraine expert perspective?
I think so. For a long time, there's always been this question, and Dr. Galati, I'm sure, will share the evidence. Kind of goes up and down, and we say there's a strong link. Well, maybe there's a link. We're not sure there's a link. What is the link? And so a lot of studies are undergoing now. A lot of researchers are looking at this, but I think from a simple perspective, it's one person with a brain and a heart, and so whatever's going on in the body can impact both of those. And so migraine, there is a vascular component to migraine, but we've also learned in recent years that there's a lot of what we call inflammatory change going on. There's a brain vascular connection. So if there's a neuro or an inflammatory process going on in the brain that might link to migraine, one could theorize that there could be an inflammatory process that impacting the heart. And so, for example, we also understand that things that impact the heart can also lead to a change in someone's migraine. So, migraine with aura, so that's a migraine attack with head pain, light, sound, smell sensitivity. A small percent of people experience the warning or the aura before they notice the head pain. And that might be a visual change, and that might be for some individuals tingling or a sensory change. Those individuals, there seems to be a higher chance potentially that they may have a small opening in their heart, which is probably from birth, called a PFO. I'll let Dr. Galati talk about that a bit more. So right there, we have what could be a direct link between something going on in the heart that impacts how migraine presents or the attacks that a patient experiences. So I'll maybe let Dr. Galati just talk a little bit about PFO.
Well, yeah, if I could just go back just a touch, because I think you made a really great point, about the link between the brain and the heart. And what's very interesting, anytime we see those relationships, it's much stronger in women than in men. So there is something biologically different, obviously, about females versus males. And this may be one of the things as well to add to that mix. But I think, yes, you're absolutely right that we know that sometimes migraines can be associated with patent foramen ovale, which is a PFO, or even atrial septal defects where the atrium basically they're connected to each other, but usually blocked. But if there's an opening, a defect where blood is going from the left side to the right side, that is not normal. And those are people that are more predisposed to experiencing migraines. And so we still, right now, we don't universally recommend everyone with a patent foramen ovale who has migraines to get that PFO closed.
Yeah.
We don't actually have strong evidence that that closure improves your outcomes or improves even the migraines that you're experiencing. So that's really something you need to talk. It's actually really a team thing where we need to meet with the neurologist and the cardiologist coming together, making decisions with our patient about whether even considering closing is important, but identifying a patent foramen ovale or an ASD can be part of the workup that will be done for people experiencing migraines.
For sure. So if someone has migraine with aura, for example, and they always have their migraine with aura attack during exercise or after exercise or anything that involves physical work, and we find out they have a PFO, but as Dr. Galati says, it's not big enough to close. There's risk of closing a PFO. We might say in conjunction with the cardiologist, maybe this person is a candidate for a daily aspirin, for example, or something a bit stronger. So this shared decision making, which Martha and I talk about, and Carrie, we've talked about this, is critically important for patients, particularly the population that we see, women in their mostly 40s, 50s, 60s, who might be experiencing a worsening of their migraine issue and perhaps developing other symptoms, chest pain or racing heart, and they want to get it sorted out.
Well, let me ask you this. If someone's watching and they've been seeking treatment for migraine care and they're trying to get their symptoms under control and they kind of hear this and go, well, I do think that when I was born, there was, the valve didn't close or what I was told was this. Is it worth simply calling their cardiologist and saying, can we check on this? Should we look at this again? Like, is there high enough evidence that someone should kind of this should pique their interest?
I would say from a migraine perspective, no, because PFO is so common. Perhaps
Okay.
1 in 4, if I have my numbers right, will have this. And for many, it's small, it's not significant, it doesn't create issues. It could be the source of an unexplained stroke in a young person potentially. But I think unless the patient has symptoms or the cardiologist is auscultating, listening to the heart and says, well, something's off there, I don't think we would go just looking in everyone and sending them off for a test to look for it. Because if you find it, you might not need to do anything about it.
And that's my biggest worry is like sometimes when we find it, I'll blame the cardiology community. We have the ability to close these things, and depending on whose hands you get to, they may think PFO closure is in fact the answer and may just convince the patient that that's the right thing to do. The thing is, as Dr. Lay said, it is very common. You can find PFOs if you do echocardiograms, and whether it's always the problem isn't always clear. And also closing it, as I said, we don't have good evidence saying closing it improves migraine. So I hesitate that, because I think patients themselves, once they get it, they'll start also thinking, is this, does it need to be closed? Sometimes nothing needs to be done. And that's sometimes hard for somebody to accept because they're like, I'm having pain. What if they just close
Yeah.
this and would it all go away? It's sort of a false hope sometimes that we're placing for them.
Yeah. Are there
Think
medications that can also help with that, without doing a procedure?
I mean, not necessarily a medication that changes what's going on and the physiology that might be contributing to migraines, but um, you already heard that sometimes we'll recommend aspirin that patients would benefit. Again, with our migraine patients, we have to find out also how many other NSAIDs they're taking to balance
Great
that.
point.
But I do think that sometimes we will recommend just taking a baby aspirin. Again, because this issue with migraines occurs more frequently in women, and women also have more bleeding. Again, this is another time that we end up talking about, like, what medications can we give, and am I putting this woman particularly at a higher risk of bleeding? Because aspirin, seems benign, but I
right.
will tell you, as a cardiologist, it's not that benign.
Mm.
We have a lot, I can't tell you how many of my women have, bleeds because they might not take aspirin with food, or they don't eat enough as to begin with. So they take it on an empty stomach and then they end up having bleeds. So it's not as benign as, some of our commercials might make you think.
Yeah.
Right.
I actually love that comment because I think one of the things, Dr. Galata, you are speaking the language of what I would imagine Dr. Lay probably sees is how many people who come in and they're taking tons of pain relievers. And that's a great reminder that, as a cardiologist, you're seeing this. This isn't just don't we hear the commercials and the warning labels have gotten longer and longer. But I think that's such a great reminder because and Dr. Lay, do you have anything to add to that? Because I'm sure with the vast amount of people before they get to a neurologist and they're trying to be treated for migraine, they're probably on a lot of pain medicine and not thinking about the cardiovascular risk. Or do you see that a lot, Dr. Lay?
I think a lot of people, I mean, as we've indicated, migraine is incredibly disabling. It's one of the leading causes of disability worldwide. So people want to feel better. And I think any provider should and likely does take a pretty detailed history about medications. But then here again is this overlap, right? So for many migraine patients, we use blood pressure pills to help to reduce the burden, the frequency, the severity of the migraine attack. And so, we often have to communicate with the cardiologist. Cardiologists may have them on blood pressure pill A, and I'll say, well, they have high blood pressure, but they also have migraine. Could we switch blood pressure pill A to this other one that has got better evidence for managing migraine? So evaluation of medications is always critical, I think.
I think also the other thing is that we aren't always as good about asking things that are over the counter. And so some of the pain relief medications, the NSAIDs that you can buy over the counter, probably I'm guessing the neurologist asks about, because you guys are very skilled at knowing and wanting to know everything that they take. But sometimes that's the barrier, because at least I'll say for my community, we forget all the things people are taking that are not prescription form. And
Mm-hmm.
if we forget to ask those things, we may not know. And so that also creates a dangerous setup if they're taking a lot of NSAIDs and then we decide to say, oh, take a baby aspirin a day. What else are they taking? And I think it's really important for patients to know when they go to the doctor to tell us everything you're taking, the supplements that you're taking, the over-the-counter pain medication that you are taking, as well as your prescriptions, because it might matter for a lot of different things.
Mm-hmm. And
That's a great piece of yeah.
some women forget about the birth control pill, right? Because it's
Oh,
just
yeah.
something they've taken a long time. And so you really have to go over that and find that out. Because, if we look at common things being common, and risk factors, lifestyle, maybe some medications are probably the foundation of how migraine and cardiovascular risk come together? You know, are people smoking? Is their cholesterol okay? Is their sugar okay? How's their blood pressure? Are they walking regularly? Are they getting engaged in sort of mindfulness activities? Do they have a history of childhood or young adult trauma or adversity? All of those factors play a role in elevating the risk, particularly if we see a young woman who's on the birth control pill. I always ask about smoking,
Yeah.
because that's where the risk really compounds, right? To put someone at risk of a stroke potentially is a young woman who seems otherwise healthy. She's on a birth control pill and she smokes. So it's not so simple all the time.
Yeah. Yeah. I
Absolutely.
love that. Yeah. Dr. Galati, go ahead.
Oh no, I was just agreeing. I was just agreeing.
No, that's great. That's great advice. I feel like sometimes the warnings we see are so vastly, they're getting longer and longer, so people are paying even less attention because you'd hear smoking in pregnancy, and I remember that as a child, that's what you heard. But now it's getting where you're like, oh, let me go refill my coffee because they're continuing to still talk about the 20 things that could happen. So I think the reminders you're bringing up are so important. Both of you mentioned shared decision making and the conversations you're having. How does that play a part in trying newer migraine medications and therapies that are coming out? Like, how do you put the cardio with the neuro and bring your team together?
Well, I can start. I think that obviously, again, like I said before, caring for such a patient is a team sport. And at first of all, you have to hope that the neurologist and the cardiologist are talking together as much as talking to the patient so that we know we all have different levels of expertise. So I'll never claim that I know all the newer drugs for migraines as well as a neurologist, but we know what potential effects are for the cardiovascular system. And that's why we're there together. And but for the patient, I think that, sometimes as a patient, you might think we'll have all the answers.
Mm,
And actually, I hate to disillusion them, but we don't always know all the answers. As new drugs come out, sometimes we learn as new drugs come out that there's issues that we didn't see in the studies, but we start seeing in real life
yeah.
that potentially could affect the heart. And really, it's when we put the patient at the center of everything, which is what we should be doing for any patient, but particularly for migraines, is telling what we know and what we don't know. And obviously, we have to weigh into the factor all the other medications that they're taking or the medications that haven't helped them, because sometimes there's not additional options. They've been on other medications, either they have side effects to them or they didn't help them at all. Okay, if we're going to try then a new medication, we might need to accept that there might be potential cardiac risks. Are we willing to take those risks? Sometimes for a patient who already has established cardiovascular disease, those risks may be greater than somebody who doesn't have established cardiovascular disease. And it's really weighing the benefits with the risks, because no medication is without risks, but also medications are with some benefits. And that's why we're choosing them. But we have to weigh the two so that we find the right medication and that the patient understands the potential consequences of using the medications, and understanding what the patient's value systems are and what they're trying to get at. If somebody, for example, has been suffering from migraines for a very long time, all medications are really not getting relief, what many people are living with is they want relief. And sometimes the long-term consequences of the medications is not the priority. And I totally understand that
Mhm.
quality of life really does matter. And we have to weigh that, and we have to really be upfront and honest with our patients that we don't have every beautiful trial that we want that will answer everything for every individual in front of us.
Mm, mhm.
And I think sometimes it goes beyond the heart and the brain. So I'm thinking, for example, of our patients that we have, they have sleep issues and you find out they have sleep apnea. Oh, I hate the mask. I can't wear it. And while we appreciate that the mask isn't pleasant for sure, and maybe wearing your CPAP mask doesn't cure your migraine, but there are important cardiovascular implications of untreated sleep apnea, right? So we often have to have that shared process where perhaps I'll communicate with the cardiologist who's also communicating with the patient and me. We say, listen, you need to wear your CPAP mask. That will help your heart and it may help your brain. And so we're, knocking down these risk factors, because I think one of the newer areas for risk factors, why does high blood pressure or stress or bad habits, what is it actually doing? Well, there's this, and this is not my area of expertise, but there's a thin layer of cells, the endothelial cells, that kind of line and protect our blood vessels. And that lining, is important because it enhances or helps blood flow the way that it should. And so endothelial dysfunction could be a link between migraine related stroke or cardiovascular disease and heart issues. Where does that come from? Oxidative stress, as we call it, inflammation, high blood pressure, poorly managed diabetes, cholesterol. So again, we go back to looking at the patient as a whole person. What are all the different things that we can help manage? Even if it's not my area of expertise or it's not Dr. Galati's area of expertise, I think we can educate the patient about the importance of addressing those risk factors.
And I think it's so important because one of the things that we immediately do with our patients who do come to us who have migraines, the first thing that I tell all my trainees to do they have high blood pressure? Do they have high cholesterol? Do they have the metabolic syndrome? Do they have evidence of increased inflammation, and do they smoke? I'm like, always ask them about those things, because those things we can do something about. We may not be able to do much about the migraine. We may need to leave that to our neurology colleagues, but we can help with things that are potentially contributing, like you said. And that whole idea, the endothelium lining is throughout the vascular system. So it's in the brain, it's in the heart, it's in the entire body, because we have arteries that go everywhere. Well, they are responding to stress, and some of that stress comes from those traditional risk factors, including, like you said, a very good point about sleep apnea. People don't understand. They may not feel well just wearing that annoying CPAP mask for one night. It's not going to be a one night thing. It's a chronic exposure to less oxygen, which is also a stress ultimately to your vascular system. And so these are things that, we want to address so that potentially people can have less potential cardiac events down the line too, but maybe also might help with whatever's going on triggering the migraines.
Dr. Galati, I love one of the things you said that resonated with me that I hear from our patients is that sometimes people don't realize the seriousness of migraine, and they'll hear that, we say this phrase a lot, it's more than a headache. There's so many symptoms that go with it. And when you hear about heart health, there's a feeling of like, oh, this is your heart. Like this is highest priority, heart health. One of the things that I really love about this conversation is even if you're masking your pain with NSAIDs and over-the-counter medications, you could be hurting your heart while trying to just adjust to the day-to-day life. And one of the things Dr. Lay and I talk about and this community discusses is that we've got to be okay with okay not being enough. You guys, and in bringing that in full circle, when you talk about shared decision making, this is a question for both of you. If somebody's watching and they're frustrated and they're like, oh, my cardiologist or my neurologist or whoever, well, they don't talk to my other doctor. How do they make that happen? Is that like, let's say you're not in a practice that they are both expertise. Do you put them together? What does that look like for patients who may be in more rural areas or more in underserved areas? Do they link up their two doctors?
Sadly, I'd say probably no. I mean, I think one of the big things about women's health in general, and since migraine disproportionately affects women, I think of that as a female specific risk factor that I ask about. But I will say, in people who don't treat migraines necessarily, that's not our focus, right? Most of my colleagues will think a migraine is just a bad headache, and they get them more. That's what if you ask my colleagues, they might not understand the importance of really knowing whether somebody has just a headache versus a migraine. Yeah. So I think it all goes to education. I think that at least that's one part of it. I do think we need to really be trained better to understand what a migraine is versus what a headache is. And I think that is something that's lacking. And so when somebody's in perhaps a more rural area and doesn't have necessarily a headache specialist, whether it's primary care, whether it's somebody else that's caring for them, the problem is I don't think that the seriousness is always known to the physician. And I think that is a big problem. I also think, again, because migraines occur disproportionately in women, we discount women's symptoms very easily. And I could, we don't have all day, so I won't talk about all the discounting of cardiac symptoms that I see on a daily basis. We discount when people will have chest pain. We say, oh, for women, oh, it must be anxiety. A man can come in, have they've put a nail through their hand, and somehow they get an EKG because somebody's thinking about their heart. Well, the same with migraines. I think people think, well, oh, they just suffer from migraines. They, like sort of discounting what somebody's experiencing. And that, unfortunately, is a thing that women at every level, at every organ system experience. And so I'm hoping we'll move away from that. It's going to take a lot. We've spent years trying to change just medicine the way it looks, meaning that there's more women in medicine now, which is a great thing, but also in specialties like neurology and cardiology, which are sort of, specialties that have been heavily male dominated. We need to start changing the way we talk about symptoms and change how our community understands them as well.
I love that. I love that. Before we close up, any final words from either of you? Because I feel like we could keep talking all day. I keep thinking of more questions and going, oh, I probably should stop now. Do either of you have words of encouragement? I guess that's always a good place to end our conversations of if a patient is frustrated and they're, having heart issues, but they also have migraine pain, which I know there's a big audience of women especially who go through that. Any words of hope for them? Dr. Galati, I'll put you up first.
Okay. Well, I think that I guess I'm not sure if I'm going to answer your question exactly because I think Dr. Lay might be the better person to answer it. But I will say that when women aren't getting their answers or aren't, being heard, that it is time to ask for a different doctor, to be referred to a different person, ask for a second opinion. We do deserve answers. And I do think that empowering our patients is so important because we can't fully manage the entire medical system. We would love to, but we can't right now. So we have a lot of work to do on our side, but patients also should feel empowered and try to get the answers and not think that their life was meant to suffer. I don't think that that is what was intended. And I think that there are solutions, but you've got to get to the right person who's going to be your partner on that journey.
I love that. I think that is so well said. And I certainly put you on the spot saying, here, let's go with these closing lovely words. But that was really lovely. And I think people forget that as we said, good is not okay. Like we want you to be great. We want you to have more non-headache days than you have other symptoms. We want you to have symptom-free days and more of those. Dr. Lay, any words of encouragement from you?
Yeah, I think that's a great highlight to end on because it really is about empowering yourself as the patient, asking questions, not feeling guilty about asking questions, not feeling badly because good isn't good enough. And I think American Migraine Foundation is working very hard to change that. We're trying to educate patients. We're therefore also educating, some providers about what migraine is. It's a brain disease. It's not a headache problem. It carries significant disability, but I think one of the most important things about migraine these days is early diagnosis and early treatment are key to changing that burden over time. And, if you don't have the right provider, as Dr. Galati said, try to search for one, even if it's telehealth or online, and encourage your own provider to say, hey, you know what? I don't think my ex-doctor back home understands this as much. Could you put a little bit more information in your note back to them? And I think most of us as specialists are very happy to broaden the note a little bit or encourage the local provider to say, hey, so-and-so is talking about some chest pain or discomfort, I think they need to see the cardiologist. Or perhaps Dr. Galati might see a patient who says, so and so is telling us about their headaches. They really fit the criteria for migraine. I think they need to see someone who has expertise in migraine. So the shared decision and patients being advocate for themselves, us advocating for patients. But the bottom line is there's a lot of hope ahead because we're changing the game. We're improving things for people that live with migraine.
I love that. And I would also end from our side on this is why we exist at American Migraine Foundation is to get this education out to help people. Clearly, the three of us can't do it, and clearly our small team can't do it. Even with our board and editorial board, it's going to take all of us. And so this is why I think it's so important for patients to tell their story. It's always a great when people share their story and they're sharing it on social. It gives their family a chance to go, oh, I didn't realize it was that bad, and that
Yeah.
one story can just spread like wildfire. And I just encourage people to consider that because that's a way that you can help us get the word out about what really migraine is. So thank you both. I could talk to you, like I said, for hours. I feel like we are so fortunate to have you both on today, and thank you for your commitment to both of your fields and for what you're doing for patients across our country. We're so lucky. We need a lot more of you. We need to explode with both of you. So thank you both for your time.